Okay, second part is cardiac CT. At Methodist Hospital, we have 3 cardiac CT reader. We also a nuclear cardiologist, which is kind of like trends in the country that if you do nuclear cardiology right now, most of the people would also do CT. Kind of fit into each other because cardiac CT, the main application right now is coronary CTA. So really quick overview. I'm not going to give you data or anything like that. Just want to show you examples, pictures, to impress you, hopefully, and give you some idea about the potential of CT. So coronary indication. First part, I'm going to talk about coronary CTA, which is the main indication for cardiac CT at this stage. Why coronary CTA, right? I mean, you can just cath the patient, but you're probably familiar with this data. This is already several years old. Data shown that the low diagnostic elective coronary angiogram, okay? You heard about it. Almost half or close half of the angiogram we do in this country basically has no significant disease. So the process of choosing the patient to go to the cath lab, we're not doing a good job. So essentially, the major strength of cardiac coronary CTA is the negative predictive value, meaning that if you have a negative or normal CTA, 98, 99% of the time in a reasonable quality images, you can exclude significant coronary disease. So basically, it can work very well as a gatekeeper to the cath lab. It's going to avoid a lot of non-diagnostic cath. So just a real quick rundown of the indication. So any symptomatic patient with chest pain, syndrome, ischemic, low to intermediate pretest likelihood. Okay, right now in UK, the first test to be ordered instead of stress test is coronary CTA. Just to give you an idea, this is a regular 64-slide CT. Done well, you can obtain exquisite images like this in 3D render. Basically, like this case of one of the patients we did earlier with 64 slices, older generation CTA. This is a patient with atypical chest pain, very strong family history of MI. You can see he was lucky. He's not cursed. He has clean coronaries. So this is most powerful use of this technology is to exclude presence of significant disease. Or this unlucky patient, obviously he had chest pain, hypertension. You can see distal left main stenosis pointed by the arrow, documented by the excellent correlation with the angiogram. Or this is an unusual patient who had atypical chest pain, normal stress test, has one single coronary, which is rather unusual. I don't know if that's cause of the chest pain. But right now in this country, I think it's rather difficult to get approval to get a CTA without any other test. That's just the way the market or the environment. So essentially, most of the CTA is performing patients with borderline, equivocal, or non-diagnostic stress tests, which you feel like, stress test, I'm not so confident. I don't think the patient have disease, or even if you have a normal stress test, but the pretest likelihood is not very high, since rather than send the patient to the cath lab, you order a stress test. So this is insurance company, I would say 99% of the time would approve this indication. Again, I apologize, not playing. This is a patient with 1 or 2 segments abnormal exercise echo. We went to the CTA showing that she has some underlying arteriosclerosis, but no obstructive disease. In LAD, that's where the abnormality was seen. Or this 46-year-old female with a reversible defect in the anterior wall. You can see because the clinical presentation was atypical and she really doesn't have that many risk factor. CTA show a perfect normal coronary, and the non-contrast CT show a very large hydrohernia, likely cause of her symptom. And CTA is being used frequently for triage of acute chest pain in the ED. Again, this is just some quick example. Some patient, this patient with a very tight lesion in the LAD, went to the cath lab. And the important thing is, not only you can look at the coronary tree, right? I mean, you heard about triple rule out, right? You can look at PE although it requires different type of protocol. Obviously you can look at aortic dissection, and you can find out other causes of chest pain like pneumonia, pleural effusion, hydrohernia, et cetera, et cetera. And the other major indication for now for using coronary CTAs for congenital anomaly, like this case that I saw when I was in Wisconsin, you can see alcapa, LAD coming out from the PA, okay? Again, I'm sorry, it doesn't play. This is a patient with single coronary arteries. Very interesting. She's in her 60s, has a sudden death, and stress tests show mild ischemia in the anterior apical wall. If you look at the CTA, that's the area where the single coronary coming out from the right coronary cusp barely reach the apex. So this area is definitely hypovascularized, which that caused her sudden death. I'm not so sure, but again, I don't know what the treatment it is, but I guess at least you get the diagnosis. And the third major indication is for patients with new onset heart failure, low ejection fraction, in which they don't have history of coronary disease or myocardial infarction. EKG is unremarkable. I would say instead of going to the cath lab, CTA is an excellent modality to rule out disease. Obviously, this is a patient with very low pretest likelihood, 37 years old female with chest pain and short of breath. Very dramatic ECG changes, as you can see. Echo, take my word, shows EF in the 20s. Whole anterior, whole 2/3 distal of the LV is not moving. Right now, most likely it's due to stress cardiomyopathy or Takotsubo, which was the case. Her coronary CTA is completely normal. Again, this is different patient, 59 years old. Patient come in with chest pain and positive troponin. Echo, you can see distal, this apex is totally akinetic with a clot in there. And you would think, well, probably a distal LAD disease. But no, she did not have any coronary disease. This is a rare case of stress cardiomyopathy causing apical aneurysm and formation of the clot. This is another case, a patient with low EF and normal CAT. I'm going to show you some of the new advances of technology, what it leads, what's new in coronary CTA, because the concern mainly with the coronary CTA is the radiation and contrast, obviously. And but the newer technology, newer scanner, like what we have at Methodist, allows you now to do this kind of study in the TAVR study. You can image from the neck all the way down to the thigh in 1.4 seconds. So, I mean, there's no faster technology than CT in obtaining anatomical information of the body, of the cardiovascular structure. In this case, this is one of the first case we did with a new scanner. Very, very fast, 1.7. And the other thing is the low dose radiation. This is a 58 years old. One of the first case we did had mildly abnormal borderline myocardial perfusion imaging. He's rather thin, unusual for Texas, obviously. But we were able to control his heart rate very well, and we do low KV, low MA imaging, normal, non-obstructive disease. We got it down to 0.65 millisievert. Just to give you an idea, by living here in Houston, you get 2 to 3, 2.5 millisievert just from the environment. So this is equivalent at about 3 months of living in Houston, the radiation amount that you get from the sun. The other thing is low dose contrast. You can see this is a case of a patient with LVAD, left ventricular assist device, with renal insufficiency. With the newer scanner, newer protocol, we were able to do this multi-phase dynamic study, RV to assess LV and RV function in a cannula over 30 cc of contrast. So very beneficial, obviously, if you have patient with renal insufficiency and you need cardiac CT, maybe not for coronary CT, because coronary CT, with this low dose protocol, you might not get enough contrast in the coronary, although it needs to be proven. But for structural heart assessment, this protocol with low dose is a reality, meaning If I only want to look at the LV, I probably could get away with 20 cc of contrast. The other major development is what we call CT-FFR or virtual FFR. This is a technology in a lot of research going on, and I think it's been approved by FDA. Essentially, you can get functional information from anatomical images using very sophisticated computer algorithm. So I think will change a lot of how we do things if it really clinically in the current clinical trial worked out well. Okay, the last thing I want to show you is some new advances of the CT. It allows you to do 4D imaging, essentially 3D images 3D render images resolve in time, like this case with patient with, I'm sorry, let me go back, patient with mitral valve, in this case a patient with aortic dissection. But the most exciting thing about cardiac CT is the non-coronary application. I'm going to show you some examples of what CT could be done. You heard about this, the TAVR incidence of clot has been shown to be in about 20–30%. Clinical significance unknown. This is a case of you're gonna hear about your surgeon and interventional cardiology want 4D images. This is what they call 4D dynamic images. So basically, you can see this clot, present the clot in the cusp of the coronary in the prosthetic valve. The other major indication of this coronary CT is assessment of prosthetic valve dysfunction, especially with paravalvular leak, aortic position, before they go ahead and do the plug. ECT is very useful in assessing the location and the size of the, let me see if I can. So this is the prosthetic valve rendered in 3D, and this is the leak. Okay, so it's, and this could be overlaid in the cath lab to facilitate the progressing advance of the catheter and the plug and the wire through the hole for you to deploy the plug. And I think this is the most exciting application, is to use the CT to understand how the prosthetic valve that we're putting in patients, how do they do functioning. This is a patient undergoing transcatheter mitral valve replacement before the surgery, before the procedure. Very large heart, dilated annulus, significant large annulus, and this is after the deployment of the valve. As you can see, the most important thing, it allows you to assess how this valve prosthesis behave throughout the cardiac cycle. Okay, this is extremely important for design of the prosthesis. Okay, so anyway, this is all I have to show you. Hope it will get you something to excite about what you can do as a cardiology imagers in terms of nuclear and CT.